Hi, I'm Dr. Mila Brujic, and today I'm joined with Julie Rodman, where we're going to be down with OCT on the OI show. Julie Rodman, thank you for joining us here today. So, Julie, for those people that might be living under a rock and don't know who you are, please give our audience a little bit of a background on yourself, where you practice, what you do on a daily basis.
So, as you said, I'm Dr. Julie Rodman. I'm a professor of optometry at Nova Southeastern University in Fort Lauderdale, Florida. I've been fortunate to be there for about 25 years now, believe it or not. So
It's
I've
wild.
really kind of grown older with the school and with the changes that we've made. I've been very fortunate because when I started off there, I worked just as, just a regular professor in the clinic, kind of teaching our third and fourth year students. And I've evolved into the chief of our downtown Fort Lauderdale clinic, which, as you can
Right.
imagine, brings tons of pathology and lots of fun educational opportunities. And I also took over our retina course recently. So got a
That's
lot
great.
going on, and it's really been a wonderful, very, very gratifying job.
Well, Julie, and I'm so glad you gave us the background because really the reason why you're here today is to do a little bit of a deeper dive into OCT advances. And again, we practiced in a time where OCTs did not exist. And then we saw the kind of the initial time domain, the first shot at the OCTs. And then we got into Fourier domain OCTs. And what these companies are doing now is just building machines that get more scans in a faster period of time and more accurate scans. And we now have the ability to rebuild vascular supply. And that's where I really want to do a deeper dive in with you is the OCT angiography and its functionality around macular degeneration. So give the audience a little bit of a background on what your protocol is for the MAC degen patients. What scans are you ordering for that individual?
I'll just start off by, for those that, are not familiar with OCTA, we, as you said, have historically had OCT, which we know gives us outstanding anatomical or structural images of the retina and choroid. The problem that we've had, as optometrists is that we really can't visualize vascular flow. And so this advent of kind of introducing this non-invasive modality that allows us to visualize retinal and choroidal blood flow or lack thereof has really been, I would say, a huge, advancement in the profession for ophthalmology and optometry, but specifically for us because it doesn't involve fluorescein dye, right? So all the patients that we had to send out to confirm presence or absence of blood flow, we now can somewhat do in our clinics. So that being said, this technology, I think, shines in some, particular diseases. I would say certainly in our diabetics and certainly in our macular degeneration patients, specifically, at least in the way that I use it in wet AMD, trying to figure out if patients have membranes. So, we're all encountered every day with pigment epithelial detachments or chronic central serous chororetinopathy, things that, we look at it and we look at the OCT and we're troubled where we're determining, do I need to send this to retina? So this technology allows us to visualize down deep, whether we're looking, slightly above the RPE, down below the RPE, trying to see what the blood supply looks like in these diseases. And is it something that needs to be, referred out? As far as, choroidal neovascular membranes, this technology shines. So it allows us to make, micron size segmentation, angiograms of different pathologies. So we can really localize if there is an active membrane growing. It's also gaining some popularity in dry AMD, specifically geographic atrophy, but that's kind of on the horizon. Also, grading AMD, looking at drusen size, OCT in particular is very important when you're trying to grade just, regular drusen, trying to say, is this early, intermediate, or going beyond that? So
So
huge.
Julie, are you actually doing, so I know in this traditional OCT cross section, we can actually see drusen and we can measure those drusen.
Right.
Are you measuring those to help identify the level of, or the class of AMD it is?
So the honest answer is no. I would recommend that when, practitioners are first starting to learn OCT, that they do a couple of, of scans using the line caliper so they can appreciate what a small drusen looks like, what a medium drusen looks like, and so on. But when you get good at it, you really don't need to do that. You can eyeball it and say, wow, this is a medium drusen or drusenoid PED. So I don't do it on every patient, but I do find it extremely useful when I'm trying to figure out. And I'll give you another example. We know that reticular pseudodrusen or subretinal drusen
Yeah,
is a huge risk factor for
yeah.
advancement of both wet and dry AMD. So if we don't have OCT, it's very difficult to see that these are actually reticular pseudodrusen versus subretinal drusen, or now just regular drusen. So I find it useful in so many different ways, particularly when we're having trouble making a diagnosis just with 9D or a fundus exam.
So Julie, the complexity of OCT angiography is some of its beauty, but it also is too can be overwhelming for the practitioner that's bringing it into their practice, because you see these scans and you see the different slabs that it presents within the retina. And we really relearned the retina, in my mind, when we had the advent of OCT, and now that we have the advent of OCT angiography. But understanding that the photoreceptor layer is really absent of any vascular supply in the normal individual is critical. So let's say, for example, you have the patient who's an intermediate macular degeneration patient. They're walking into your office. Last time you saw them, let's say it was 6 months ago, and you recommended the AREDS 2, no smoking, good UV protection, and now they're coming back for their follow-up visit. Tell me, are you leveraging OCT angiography at that point? Are you only starting to think about OCT angiography if you see a reason to run it? Reduce visual acuity, something doesn't look right on the retina.
So I would say with macular degeneration, I try to run OCT angiography regardless of what the stage of the disease is, because a lot of times there's things hiding that you think may be kosher and they're not. For example, I don't know if you've heard the term non-exudative choroidal neovascular membrane. So these are tiny little shallow pigment epithelial detachments that are actually full of neovascular tissue. They look just like flat drusenoid pigment epithelial detachments. So I would say that every patient that you suspect has AMD should get OCT angiography, because it will identify areas that perhaps we would mistakenly call dry AMD. So, remember that it only takes an extra, let's be on the bigger, an extra minute, 2 minutes of time to overall get the scans. You need to use OCT to get OCT angiography, right? We're taking multiple OCT images and looking at the difference in signal between the scans. We're not doing it, but the algorithm of the machine does it. And those differences are actually where blood flow is being picked up on OCT angiography. So having an extra minute, really, to me, and getting this plethora of information, if you want to say, there's no reason not to do it. Certainly, if a patient has decreased vision that we can't figure out just on regular OCT, OCT angiography is definitely, recommended or necessary. But I would say that if you have it and you need to do OCT anyway to get it, take the extra time and get the OCT angiography. And if I could just add on, preface by saying, yes, it is a difficult technology to learn. But just like when we first got OCT, right, Mila, you remember when we first got OCT, you have to learn it, you have to practice it. Once you learn OCTA, it's still more challenging, I'm not going to lie, but it becomes easier, right? It becomes more secondhand and easier just to look at and interpret quickly.
Well, in addition to that, too, when we're using the angiography in particular for macular issues, it's not usually, those scans are usually the ones that turn out okay. It's usually when we start doing the glaucoma patients and they have to move their fixation where it becomes a little bit more
Yes,
difficult. And if you have to redo the scan, those are usually the scans that have to be
correct.
redone as well, too. So Julie, give me a case where you did OCT angiography and you said, well, I'm going to do it just to make sure that there's no new blood vessels forming in this region or this location, where it surprised you and you said, oh boy, we
Yeah.
are now changing the path for this patient.
Yeah. So, I work in a highly African-American community. My population doesn't get a lot of wet, AMD just because, or coronary vascular membrane, just because of the demographics. So I had a gentleman that had what looked like a very large pigment epithelial detachment close to the macula. Told the student it looked drusenoid to me because it had a kind of a hazy yellow appearance to it. But I said, let's get OCTA because we have it, right? And let's see what's going on.
Mhm.
And it just showed us bullseye right there, believe it or not, this, hazy area under the RPE. It did not look homogeneous in nature, which in itself tells us that there's probably something not good going on. And then if you looked at the choroidal slabs that was underneath the RP, obviously, you could see that there was this neovascular frond. You find with OCTA, a lot of times we find neovascular fronds that kind of have been lying there and dormant for a long time. And sometimes retina specialists choose not to treat them, but I still feel like it's in our wheelhouse to identify them and get them out for the possibility that they will need to be treated. But the biggest thing I think that always surprises me when I have either CSR that's chronic or PEDs that I think behind the slit lamp look fine. And then I go do OCTA and I'm like, oh my God, it's a good thing we did OCTA. polypoidal, things like that, where you just can't see what's happening underneath the mound, and you really need kind of this look right as to what's happening.
I think looking just as eye care over the next 5 to 10 years and looking at the supply of retina specialists and
Yeah.
the ability to get into retina specialties is making us needing to become more diagnosticians. We need to become
100%.
more refined in the way that we're sending these patients over. And we need to be more critical in what's that defining characteristic that's going to create a referral. And 20 years ago, there are things that I may have referred where today, because of the technologies we have and the way we have to image the retina, I feel much more comfortable monitoring those things because I know that there's no treatment for something like that,
Yeah.
or it's something that is a time thing that will make this better as opposed to something that needs to be treated. So,
And Mila,
so
I tell my retina students every day when I have class that if they don't choose something they love, whether it be disease, whether it be dry eye, whether it be myopia control, do something and do it to the max, because otherwise you're
yeah.
going to get bored, right? So embrace something, be comfortable with the technology, learn to co-manage things so you're not sending every single patient out, right? What's the purpose then? You're doing what's better 1 or 2 all day. Well, that's boring within a week, right? So get good at something, become and take ownership of it. I like to feel like I'm practicing at the top of my game and taking, the best care of my patients.
Julie, that's fantastic. I love this conversation. Absolutely love it. And we'll definitely have you back on a future episode and a future show. Julie, thank you so much for your time. We truly appreciate it.
It's good to see you. Thanks for the invite.
And thank you all for joining us on this episode of the OI Show, where we were down with OCT with Julie Rodman.